This week on the BackTable podcast.
A little dissection's like a little pregnant, right? You have it, you have it. I think every ballooning you do causes dissection. How relevant is it to your flow, to your hemodynamics in your vessel? That's kind of the question. I don't think we have an excellent predictor. I think everybody can do the eyeball test and say, that's fine. And a lot of that's based on what time it is of the day, what you got left. You're like, that's not significant. That's not flow limiting. I don't know how many people have decided what exactly contributes to flow limiting in some kind of like scientific sense.
Hello, everyone, and welcome to the BackTable podcast, your source for all things endovascular and more. You can find all previous episodes of our podcast on any platform or our website. You can follow us on Twitter, Instagram, or LinkedIn, and keep up with the latest updates and give us feedback through comments. This discussion is supported by Shockwave Medical, developer of Intravascular Lithotripsy, or IVL, which uses sonic pressure waves to fracture superficial and deep cardiovascular calcium. IVL is delivered on a low-pressure PTA platform and is indicated for a broad range of interventions from the iliac arteries to the pedal arch, including calcified iliofemoral vessels to facilitate large bore access. Across multiple studies and vessel beds, IVL's intuitive platform and unique mechanism has demonstrated results that are predictably safe, distinctively intuitive, and consistently effective. Learn more at shockwavemedical.com. I'm Sabeen Dhand, an IR in LA, and I'm so happy to welcome back my great friend and interventional radiologist, Dr. Kumar Madassery from Rush in Chicago.
Great to be here, Sabeen.
Oh, yes. Kumar, this will actually be your fourth time back on our show. Either you have nothing better to do, or you are a genius at multitasking the 1,000 things you do for PAD.
Or you can't find any suckers willing to emulate themselves on podcasts for medicine.
No, seriously, man. Thanks for being here. It's awesome having you back on. And I'm stoked to talk more about our topic today, which is going to be, attacking these below the knee, terrible lesions that all of us kind of deal with on a daily basis treating PAD. Look, we've talked about non-invasive imaging, before on different patients, but is there anything on the non-invasive imaging that kind of gives you a clue as how much calcium you're going to see on angiogram?
It's funny. I think we keep trying to battle this clinical workup of these patients. And I think one of the things that we forget to look at is quite often many of these patients just have an x-ray. A lot of them are patients that come in from wound care. I mean, we do wound care ourselves. We do primary intake and management wound care, but you'd be surprised that if you just happen to look at your patient's chart that you may be getting referred from XYZ and you see they have a foot x-ray, because if they're dealing with a foot problem, they've been looking for osteo or early changes, and you're going to see the diffuse small vessel calcifications throughout the foot, or even in the ankle when they're looking at a foot x-ray. They might have an injury. They went to the ER. Look at their prior imaging and you'll find these heavy railroad tracks of calcium. And those are early non-invasive, a beautiful non-invasive idea of how bad things are even before you look at the falsely elevated ABI and everything else. Ultrasound to some degree can help. CT are tough. We've talked about this before, CTAs. CTAs inevitably are painful below the knees in many patients, especially in our patient population in the Midwest. I know you're in very healthy California where everybody surfs and smiles and says, come to California. But here in the Midwest and the rest of the real world, and even in Asia and in India of all places, I mean, the CKD diabetic population have horrible calcium. So I think we are still lacking in our non-invasive testing of it. But I think if you look at these little subtle imaging and stuff that they may already have, and then look at your ultrasounds and CTs, you'll see how bad it is.
Yeah, I'm always surprised. Most of my patients, yes, the healthy swimmers for sure. They're, the surfers, they're coming in for CLI, CTLI all the time.
Right.
No, I'm always surprised to see the degree of calcium on an X-ray or during the angiogram compared to what you see on, an ultrasound, right? Most of our patients probably have a duplex imaging as your workup, right? Are you doing a lot of CTA or MRA before or what?
No, that's a good question. I'd love to hear your, but for me, honestly, CTA or MRA cross-sectional, I don't usually get at all unless, I think we've talked about this, is the physical exam alludes to poor femoral pulses or extensive surgeries. You see a lot of scarring. The patient's unsure what's happened. They have a history of a lot of maybe aortoiliac stenting, maybe aortic aneurysms. In those situations, I'll get the cross-sectional because for me, the cross-sectional is for inflow evaluation really only. I'm not using it really for the outflow, which I consider below the knee. So I think that's my value in getting a cross-sectional. It's hard to get patients to stay still enough for an MRI. Many of them may have, because of the comorbidities, they have pacers, they have all these things that may not be MRI compatible. A CTA, it's another contrast burden. It's extra costs to the system. Unless I feel it's going to really provide that much information, such as the physical exam tells me or the surgical history, I honestly can't find a good reason to do all of them or do much of that. I don't know. How do you see it?
I agree.
Yeah.
I mean, it delays the case too. I mean, if you're trying to get a CTA or MRA, get that patient scheduled then into your suite, unless they're inpatient.
Yeah.
Some of those we can get, but it really gives me no info. Below the knee, it just becomes calcium. And then you're like, is that patent or is it calcium? And then, I mean, you have no clue
by the time you like bone window it down or window down, you can't even see the contrast anymore. So you're like, I don't know what's what here.
It's ridiculous. And so, and then ultrasound is great, but you get, maybe 3 or 4 images below the knee max.
Yeah.
And there's no way you're going to know what you're dealing with. So
I think, but I do think that ultrasound part, we need to get better at understanding how to utilize it more below the knee, below the ankle, and maybe with the ultrasound teams and technology. We have like Jill Somerset doing the pedal acceleration time. That requires a high level of skill in ultrasound knowledge and operation to really understand what you're doing. Because, what she teaches and what I'd like to bring in for that is just to show how to really evaluate even the plantar arteries, the metatarsus. I mean, there is things that can be done.
I never see that. I'll be lucky if I get a DP.
So I think there's a lot more, just like we have a lot more to standardize for all of us operators. I think even in the non-invasive technology and the staff, there's a lot we can figure out how to get better information from that.
Totally. Now, people talk about, if you read your article in seminars about rock hard calcium and conclusions, we talk about intimal and medial calcifications. What's the difference between those?
Yeah, it's something that's funny. We talk about calcium all the time. We talk about, okay, I see calcium, or I think I see calcium. So I think we have to understand a little bit of the histology behind it. Not that I sit there and understand, pathology slides, but it's more that if you think about it, the medial artery calcification is the one that seems to be the biggest prevalence in diabetics and the kidney disease, the end-stage renal failure, the chronic kidney disease. That's where you get kind of the railroad track calcium. And that seems to be more prevalent in that patient population, as well as in general, just the elderly. It's just different from sort of what you see in the intimal. That's more of the atherosclerotic calcium buildup. That's the one that you kind of see the plaque ruptures and all that, things like that. But I think the way to think about it is if you have a patient who's diabetic and a renal failure patient, you're going to see those stiffened arteries that are not really obstructive. They're just not compliant. They are not elastic anymore that our arteries should be. So I think it's important to understand that when you're dealing with the patient population, our approaches to treating these patients you have to keep that in mind. It's not just, there's calcium in the lumen. I got to be careful. It's more the calcium's in the walls. What can I do to really affect change in that vessel if I want to get a result out of it?
Yeah. And do you feel, I know you mentioned in diabetics and renal failure patients that medial is more common. Is that, we do see that tibials are often affected mostly in those patient populations. So you would say most of the tibial calcifications that you deal with are medial.
Yeah, I think so. Because it depends on your patient, your regional or your patient population. Mine is going to be diabetics, smokers, and renal failure, usually all three. And then you sprinkle a little bit of coronary artery disease and, maybe something else into it. But they all seem to have at least 2 of the 5 big, components that that are seen in these patients. So
now, you get up there, you're doing your angiogram. Is there anything angiographically that can tell you between medial or intimal? Is there any other thing you can do to kind of see what that type of calcification is?
Yeah, quite often, I think you'll see when you see the flow patterns on your angiogram, you're going to see how it you can see either coral reef chunky calcium when you're in the bigger vessels in the big arterial disease. And then, also a lot of people now adjunctively use IVUS.
Yeah.
And IVUS, if you use that, you're going to really see where that calcium is. Is it intimal, luminal? Is it more on the periphery walls? You get a better understanding, but.
Yeah. Can you describe it like on IVUS? What do you see that makes you think it's medial? You can actually see it on the wall. If you don't want to describe it to our listeners, like how do you see it on IVUS?
Yeah, with IVUS, you're going to see obviously the shadowing, right? And you're going to see on IVUS, you can see the differential layers of the wall itself. You could see,
Exactly.
are you in the media, the intima, the adventitia, when you're talking about your disease, when you talk about, did you do atherectomy? Did you get too far, out into those spaces? You can delineate those as you do IVUS and you get a better understanding of IVUS. But even just angiographically, you take your spot image before you even do your angiogram, or you look at your native, you're going to see the calcium. And when you're talking about below the knee, you're going to see the railroad sign, kind of the tramp track calcium. That's your inclination. You tie that with the history, you kind of know.
Totally.
Yeah.
And one thing about, I agree with the IVUS, you can see all the layers. The only issue I have with IVUS and the tibials, I mean, once you start getting to these tiny tibials, even the 014 IVUS, I really don't pretty much can advance it past maybe the proximal third. I mean, it starts getting, even though it gets stuck.
I agree. I mean, the question is, what do you need to really get out of it? If you're that distal, is it going to change your treatment paradigm? Because if you're that distal, you already have problems in the above tibial arteries that you're going to deal with. So worrying about that IVUS show me that the distal AT into the DP has a problem, you should already be able to tell what you're running into. I don't think that's going to be a game changer for my treatment paradigm. It's more for, if I'm trying to differentiate, is this kind of a mixed, fibrofatty? Is it atherosclerotic? Is this luminal calcium that I should be very careful about embolization, things like that? I think that's where the value comes in.
True. When I approach these lesions or tibial disease, I think I personally put them in two different calcifications: a severely stenotic, heavily calcified lesion, and a totally occluded lesion, whether it's short or long. And I personally approach them differently, technique wise. And I wanted to kind of talk about both of these approaches with you.
Mm-hmm.
And I wanted to talk about, okay, you're there, you have your sheath up to the popliteal, and you've done your angiogram, and now you've got a severely stenotic, long lesion in the AT. What's your approach, Kumar? What do you do? I'm talking about wires and technique. How do you approach that lesion?
Yeah. So, I mean, I think what's most important is going to be your initial angiogram to see what your targets are. If you're talking about stenotic versus occlusive, you have to see how bad of the rest of the tibial is. So for me, I have usually the longest sheath possible. If my SFA and POP are clean enough, or I've treated it already, I want to get something. If I'm going up and over, I want to get at least a 70 centimeter sheath. If I'm dealing with more than one tibial vessel off the bat, I'm going to have a 7 French at the minimum, because that way I can plan on kissing tibials, or at least more than one tibial from the same axis, even with retrograde. So for me, the longest sheath up to a 7 on average, if I'm dealing with more than one vessel. A 6 is going to cover you for whatever devices you need and, snaring, flossing, but having a 7 gives you that extra channel for another 014 wire. So once I have my sheath there, usually I take a 4 French angle catheter just to direct towards whichever vessel I want to get into, if there is a proximal stump at least. That really helps you kind of engage whichever one that you're going, let's say AT, to get that early takeoff if that's a normal variant that you have. And then I switch over right away to an 014 antegrade. I don't spend any time with the 018 there. I know that I'm dealing with heavy disease, small vessel lumens, microchannels. So I go with an 014. So as soon as I get the 014 through the 4 French, then I switch over to an 014 support catheter. And that could be one of whatever. It depends on the height of the patient. If the patient's above, 5'11", 5'10", whatever, I'm going to have a 150 support catheter, centimeter length. Antegrade's always better for these. I do want to stress that. Unlike California and the Midwest, the pan.
I knew that was coming. I knew that was coming.
The pannus comes down to the kneecap sometimes, which I will recommend using a pannus retraction system, which sounds like an apparatus. It's just really good sticky pads and tape that you can get. It's kits, and they're whatever, some tech came up with this and developed a company. It's fantastic. I mean, it takes pannus all the way up to like their chin. It makes a big difference, because going antegrade can be a game changer. If you have diseased arterial vessels, chances are your iliac system may also be diseased and tortuous.
Crunchy.
A straight path is your best path.
Totally.
The shortest, straightest path. Sorry. So antegrade would be much better. In that case, I have like a 45 centimeter sheath up to the pop. Nevertheless, 014 with an 014 support catheter, smaller if I'm antegrade, because you don't want, the longer the length, the more pushability you lose. So this is predicated on if you're up and over or antegrade. So if I've already known what it looks like, I know the inflow's okay, I prefer to go antegrade in these cases. So I have an 014 support with a microcatheter support. And then I try antegrade for nowadays probably 3 to 4 minutes. And there's a wire escalation strategy that everybody kind of needs to get. We talk about this at meetings and in, trainee seminars and stuff, we say, have your own approach. There's numerous wires out there, many of them adopted from the cardiac space, but now there's more and more wires that we're all comfortable with. Typically I start with a wire that's soft, hydrophilic, shapeable, with good support. And those wires that I use initially tend to be very buggered up pretty fast. But if you have micro channels, they tend to be the best ones to kind of just sneak through something straight. If it's heavily stenotic, and I'm trying to get the microchannel, what I do is I get maybe a few millimeters of the wire past the microcatheter, the support catheter tip, and I sometimes push both together if I can see it go. Sometimes you'll find yourself, it acts like a tiny little spear, and it can go
increases
through.
the weight of the wire, basically.
Correct. You're creating like almost like the gram tip almost. Even these are not weighted tip wires. So often I'll try that first, then I'll try to just advance the wire, but you're going to often see these soft shapeable wires just kind of become deformed, curly Q and all that. From there, escalate to maybe more shapeable wires that retain their shape. They're still hydrophilic. And then rarely do I go to a CTO heavy tip wire in the tibials. I'm already going antegrade by that point. Retrograde by that point. I have such a short threshold as long as there's something to stick. We know from Fadi and CTOP and all that not that you have to sit there and classify them, but you just know that you can predict how often you're going to go retrograde. So I think most of us, you and me, we all switch to retrograde immediately.
Exactly. Yeah. Exactly. I find one of the tips that I started doing kind of early on was I do, if the patient can remain still, whether they're in sedation or GA, is that you feel like a light roadmap. I mean, if with a stenotic lesion, if you can follow that channel without the wire knuckling or anything like that, you can get through it. But if it starts to knuckle and there's a patent channel, you'll probably flick something into that channel and then, you're going, Well,
I think the thing about moving is very important in these patients. It's really tough and many people can't get general anesthesia. One thing that, a great friend of ours, Zola, kind of brought up to me and I've been trying out and we're testing it out in terms of a little study is if you do sedation with a nerve block, that helps a lot of these patients because a lot of them can't keep still because of pain. It's not going to really help your patient have restless legs or something like that, but a lot of patients that, I've kind of adopted nerve blocks in these patients with sedation and they are pretty still for the most part without pain.
Yeah. I haven't tried it yet, but I know he's talked about it and you've had good results.
Yeah. I mean, I think you have to have a little bit of selection in your patients and why they can't sit still,
It would be nice to, maybe someone can post on social media or something, how to do it and their experience or, I'm sure people are talking about it at conferences too.
Yeah.
So, okay. So you get across, say now we'll go to severely stenotic first, then we'll go to a CTO, but you have your wire across into the healthy DP segment or distal AT. It's your 014 wire. Then what devices what are you going to next?
Yeah. So, that always becomes the topic of concern is, do we have the right devices right now? It depends. If obviously we're talking about calcified vessels, the question is and you're luminal or mostly luminal for the most part, can you effectively change the compliance of the vessel? And we talked about medial artery calcifications. What can you do to improve your ballooning, reduce the significant dissection rate, and also reduce emboli? And I think in that space, the ones that I personally have had the best success with have been with laser and with orbital. I think atherectomy is valuable here. The downside is you have to remember this patient population, your runoffs are going to be potentially not great. They may have the SAD or the small arterial disease in the foot, which is kind of the bane of our existence for CLI/TI patients.
Absolutely.
So with any of these devices, no matter who tells you what, we've all been there. Some people more than others, where you do a quick little pass of whichever device, and all of a sudden you're entering a little bit of like a oh crap zone.
Yeah.
So if you feel you need to do it and you feel comfortable with it and you have enough experience, I think atherectomy can have a role because we know that those vessels are rigid. It's not going to respond to balloons by itself, or at least we know the patency is not going to be great. So whatever we can do to adjunct that because really tools wise, we don't have a ton of final treatment tools below the knee. We have balloons. We have some stents that we use that are not meant for it. And we have some stents that are finally going to be coming out that are meant for the tibials. But again, distal tibials, planters,
all that.
We're not there yet. Maybe the different drugs may be helping us out in the future.
So say you do atherectomy, or with or without atherectomy, you do orbital or laser. Then do you follow it with a conventional balloon? There's all these type of different balloons out there, like the Serenator and things like that, that have different adjunctive techniques. And then there's intravascular lithotripsy, right? What else do you do after atherectomy?
So IVL is the other one that I was going to mention in the toolbox. But if I'm using a device, whether it's lithotripsy or orbital or laser, to me, that's a pre-treatment. So if that's the case and I was able to pre-treat, I'm going to use a high pressure conventional coronary balloon or whatever else we have.
Got it.
I try to use the longest length balloon. I tend to use like the nanocross if it's a long segment, because that thing is 2 different balloon sizes in one balloon, and it's 21 centimeters. So that kind of helps. I think the number of times you limit how many balloons and the length of it in terms of the longest length of one balloon, you kind of get a maximal effect at once, because you have to worry about anticoagulation. You have to worry about how long a procedure is taking. All those things matter. If I'm not using atherectomy, then I think these other more aggressive balloons have a value. I'll use the scoring balloons, the sculpt, which you can take down to a 2 millimeter. The problem with that, and you mentioned Serenator, I believe the current up to the smallest is 4, so you can't take it all the way down yet. But those premises that you have some kind of metal nitinol cage or metal strips that pierce and increase your vessel compliance. So I think those have value, but the problem with this is that often you can't get those down till you pre-balloon.
Their crossing profile is bigger, right?
That's a bigger
what
problem.
I've seen.
So just because I didn't do atherectomy, I might have a tough time using one of these harder ones or these more aggressive balloons. So I have to pre-treat with another balloon to get the effect. So
all these steps, and then all these steps take time, which is tough.
And then you have the problem where you got a wire across, but you can't get even your support catheter across. You can't get a balloon across. So you're kind of in that predicament too. So that's the next thing you have to think about. Like, what's my next step there? So then atherectomy may be your only way to do any kind of treatment.
True. We've been all been in that. And that's where orbital screams, and laser are great for. What about, and then you mentioned IVL. It sounds like, you're doing a stone removal, and you're all, my hospital actually, when we brought it up, they wanted me to talk to urology to get privileges. It's like, what are you talking about?
It's incredible. Incredible.
Shows you, what people think sometimes, but it's pretty cool. What's your experience of using that in the tibials?
I think it's been a great addition because we have such a low toolbox in the below the knee space. So it's nice that you have a balloon that can do the same thing you're trying to do as atherectomy itself, with less of the concerns of atherectomy in the sunset, less concern for emboli. You're getting the compliance that you want. There's some limitations in terms of balloon length at the time, but they're working on that, I believe.
Yeah.
And again, the profile might be a little bit tough on some lesions because, again, it's a little bit more robust than your smallest coronary balloons. I mean, some vessels we're dealing with, you have to take like a 1.5 in now. There's 1.0 millimeter. You're talking about like a hair size balloon.
Yeah, and you can't get that, that step off to go through anything.
So I like the fact that you can use that, like the IVL balloon, you can use it for up to 10 centimeters of length because you deliver the pulses, and you can also determine where you want to apply the most of those pulses in terms of the segment of the vessel. So if you know that one area has far more disease, you know by your passing of your catheters and wires and the imaging, then you can actually deliver more pulses there and kind of deliver more of it there. So it's nice that you can specifically treat what you want to with it in a sense. So I think there's value there.
Yeah. What about, and everyone always likes to talk about sizing of tibials. We've talked about IVUS. You're not putting IVUS all the way down, not usually all the way down to the pedal. How are you sizing, when you're talking about all these devices, whether it's conventional or scoring or this or that, how are you sizing your tibials?
I like, the beauty of this, I think we know this amongst our CLI friends who do a lot of is everybody's a purist when it comes to talking. But I think in reality, we have people who say 100% IVUS every single time, which is great. And that's something you can 100%. Do and utilize. That's great.
Yeah.
I think what it's helped us understand is maybe we've been under-treating in the past. The way I look at it is maybe 5, 6, 7 years ago, in the beginning, I was using probably very small balloons from the mid-tibial down because these are small vessels. Yeah, like the proximal tibial, use like a 2.5 and you kind of pat yourself on the back. But in my mind, mentally now, after we've done enough and we've used IVUS to learn and others far smarter people have shown me, I'd say from nowadays, I say if I want a 2 millimeter at least in the pedal, and then I want to get up to about a 4.5 in the proximal tib. in most patients. Now, you may have to take some caveats for elderly females, some of the other patient demographics that may have smaller vessels. But I think in general, that's where we go. And if there's a question, you look at your angio, you look at your other vessels, you can look at the contralateral side or IVUS if you need to really confirm what you're doing.
Yeah. I mean, I just want to repeat that for our listeners. That is 4 to 4.5 approximately in the tibials. I mean, people will think they won't even go above 3 or 3.5. So that is definitely larger.
Well, think about it. I mean, we say pop used to be all, mentally we say 4.5 to 5.5, somewhere that people are considering 5 on average for pop. So
yeah,
to consider that you go from your P2, P3 to down to like a 2.5 in the proximal tip.
Doesn't make sense.
It's a crazy taper. That's
Right.
probably not what it was like. And if you always look at those calcium on when you're doing the ballooning, you see the circumferential calcium on your spot image. You can always see the balloon is always so small compared to the calcium itself.
Oh, yeah.
Your underside, you always can see that. And you're like, man, I'm really going wall to wall. But remember, like the wall is built with calcium. So if you can if you could treat some of the calcium, you could expand that better. It's not elastic at that point yet,
Totally. And so when you do the post-plasty, I mean, I guess what is your endpoint? Say, okay, fine, of course, the vessel looks great and clean. You've got more flow, you've got wound blush. What if you have, and especially in these calcific lesions, like a little dissection angiographically or on IVUS? How do you approach those?
A little dissection is like a little pregnant, right? You have it, you have it. I think every ballooning you do causes dissection. How relevant is it to your flow, to your hemodynamics in your vessel? That's kind of the question. I don't think we have an excellent predictor. I think everybody can do the eyeball test and say, that's fine. And a lot of that's based on what time it is of the day, what you got left. You're like, that's not significant. That's not flow limiting. I don't know how many people have decided what exactly contributes to flow limiting in some kind of like scientific sense.
Yeah, exactly.
It seems to be like a gestalt, like the ocular reflex, like, I got another case. I got a meeting to go to. That looks pretty good. No, but I think when you see a dissection, a dissection. If you see it, to me, in the tibials, you have a lot less wiggle room to leave a dissection.
Yeah,
because that's your outflow from everything else. When you have dissections in the SFA, you can't necessarily leave those alone. But unless it's a major one, you have a lot more pressure head coming in. You have a larger vessel. You have more room for that. But a tibial, that's literally you just spent, an hour and a half fixing a 25 centimeter occlusion and then leaving a dissection if you can avoid it. So when your eyeball shows you the flow, you can see the contrast having like a differential flow, or you throw an IVUS in there and you see the flap actually in the lumen. I think that's something that warrants treatment if you feel like you're actually trying to reduce the number of times the patient comes back.
Yeah, I think also the density, if you see the density of the contrast significantly different, you might be catching the flap on FOSS, not perpendicular. And that's significant.
You'll see the flap. It'll either be a spiral or you'll see the top and bottom if you had a CTO that you went, entry, re-entry.
And you said it too. You just spent an hour and a half. This is what I tell all my younger guys too, who are doing PAD in my practice. It's just, you spent all this time, you went retrograde, you did all this, and you have this result, and you're like, should I treat this? I'm like, that's the thing that's going to take this down. And by the time the patient leaves, the recovery, treat it. If you have devices to treat it now.
The question is there a system to tell you this is significant? I don't think we have nailed it down yet. I mean, IVUS really can have you proof of why you did something else, but when you see the dissection, and if you can't see it, then you should get some more experience looking at angiograms, but you can always see it in these vessels. There's people who are saying, if I see any dissection, that's going to, we have Brian Fisher, fantastic friend of ours, amazing surgeon. He'll say, if you don't stent that dissection, you're doing a disservice.
Yeah.
And that's to each their own. I mean, but using prolonged balloon angioplasty, if you feel that's your best bet, using the balloon expandable stents, which is the current marketing stents that we have that are not meant for it, but we use it, or TAC, depending on it. So I think we have ways to treat it. We don't have enough drug-coated balloons to kind of maybe say that might help the dissection not become significant. I don't think that's the right way to go yet.
Anyone doing like atherectomy for a dissection? I think I've heard people like throwing that out there. I've never tried that.
I've never tried it. I feel like once you have a dissection, then you try to be more aggressive with that dissection. You may get into that adventitial problem, just personal fear.
And you mentioned tax too. I mean, we've been trying them out, and how have they been working in your, they're IFU, they're meant to go all the way down to the ankle, if I'm correct. Yeah. I haven't done that yet. And so my experience with that is limited.
Interestingly enough, I think most of the dissections that you see that seem to be pertinent are the ones you see in that proximal to mid tibial arteries. The nice thing about the tech, I think, is that you can spot stent, your spot treating, just like we talk about in trials with the SFA bailouts. When you have a long lesion, can you treat the lesion but spot stent where you need to? To me, this is kind of like a patchwork and fix only what you need to fix, because otherwise you're unnecessarily putting scaffold where you don't really need it. So being able to put something that conforms to whatever the vessel size is, that seems to make more sense, which is why we're waiting for the self-expanding tibial stents rather than what we have now. So these tacks are self-expanding, so they should go to the size of the vessel that you treated. And then also places like the AT bend, that's not a great area for sometimes stenting. It's a little tough, but the tacks can lay down well there. So if I see
great.
flaps that have you can see the segments that you actually need to tack, it's nice to be able to spot treat it rather than cover or treat unnecessary segments of it. Because that when you stent something, it's not like a one and done. It's going to be great. We know this from every part of the body we do it in, especially at tibials. Putting more and more stuff in there is not going to be the answer.
Yeah, absolutely. And we've been talking about severely stenotic lesions, but all of this stuff really applies to both, CTOs after you cross and plasty or treat, then you get into this same discussion. For a totally occluded calcific lesion, is there, and you're obviously not going luminal. If anyone says that they're going luminal totally, then more power to you, bro. Yeah. You're obviously a subintimal or whatnot, extraluminal, but do you avoid atherectomy then? As far as the algorithm we just discussed, everything else the same, but avoid atherectomy, or you still do it?
I don't think there's a hard and fast rule to avoid it completely. I think when you go through a long CTO that you have an entry, reentry, I think those entry, reentries might be areas that if you have an experience, you might want to consider some atherectomy, because those areas may be the hardest to get a vessel complete expansion. The subintimal space, it's a great space. Well, we know this from the SFA pop area.
Yeah.
When you have a heavy calcified occluded vessel, that subintimal space will expand nicely. It may not stay open, unless it gets enough pressure through it. But where you enter and reenter, especially if I have to use like a reentry device into the tibial, that's going to be a tough spot of calcium. So you're going to have like a entry calcium ring around it. So I think in those areas are ones I may consider atherectomy, just because I know I need the vessel to be open there. Just like when you do a DVA, you need that connection to be open.
Yeah.
To stay open, not just from the blood pressure alone.
It's your inflow.
I don't ever advocate, and I don't think you should, long segments of minimal atherectomy. I think that's maybe a little bit hazardous. More power to you. I think directional, that could be very dangerous in that entire space. But if you need to spot treat just to get your final treatment there, I think that's where the value is.
Yeah. And you've had awesome presentations at multiple conferences I've seen of just like really, really complex calcific tibial CTO recans. I mean, the techniques, and they're a little bit too advanced to talk about now, but I mean, putting retrograde balloons or snares and staring, I mean, these are all really good things that I encourage our listeners to, go see one of these. You usually show some awesome case every time I've seen you talk. So
thanks, man.
You have, and I know you're working on a direct perineal retrograde, recanalization. I mean, you've definitely done a lot in the tibial space. Anything down the line that you can think of are worth talking about, like tibials?
Yeah, I think the self-expanding stent, once we actually have it available, I think we'll have to see how that plays out. It seems like it's doing really well. We were part of the study, and that's great. Unfortunately, COVID hit during one of them, but so that was a little difficult. But
why has it been so long that a self-expanding stent has not been made for the tibia? It just makes no sense to me.
I think that there's always a lag between demand and industry and connecting the dots. I think because we've all used the coronary drug-eluting stents for so long, and we said it's been great, but now we understand that the infrapopliteal space is another whole sector that we need to address.
That's true.
And then,
that is true. That is more recent. I mean, within the last probably 10 years, I mean, within the last 3 years, we've been talking about pedal and all that, below ankle. So,
and then
you're right.
The other thing is the below the ankles coming too. We still have that's even a harder area to deal with. But the other thing I'm wondering is, there's studies now on sirolimus-based drugs for below the knee, because we know that the paclitaxel stuff below the knee had some issues and it got halted. But
true,
I think future BTKs and study looking at that with limus-based drugs, because we know from the coronary experience.
From the coronary, I mean, that's what we're using the balloon expandable sense and the limus are all limus, right?
Yeah. So I think between dedicated tibial scaffolds, maybe a different drug-coated device or balloons, whatever. And then also, we're still understanding the DVA space, the detour type of space for below the knee. I think those are kind of the things that are coming because I don't believe there's a lot of options there no matter what technology you come up with. So whatever we could do to do better with as we progress is all we can do right now. And then we have to remember that no matter what you do above the ankle is now going to be predicated on what's going on below the ankle. So just like, you put a stent in the SFA, great, but what was the runoff for that thing to stay open? Whatever you do in the tibial space, you have to be cognizant of what the runoff is in the foot. That's going to be one of the biggest rate limiting steps for whatever you do in the tibials as well.
Yeah, no, that's great. Well, Kumar, this has been super educational. It's been awesome.
Awesome, man. It's always great.
Again, having you on the show is just great. It's a plethora of information, all the tips that we're learning. So thank you for being here. Thanks for answering all my questions.
Thanks to you guys. Thanks to Aaron. Thanks to Caleb. Thanks to, Barraza, B-Money, and everybody else involved in this. I mean, it's been great.
Yeah, well, no, we look forward to having you on and we look forward to conferences coming back, seeing you in person. There's lots of stuff coming up. I know you just probably came back from Viva and we really look forward to just learning more.
We have a lot more. Speaking of learns coming up for SIR, it's virtual.
That's right.
Everybody attend. We got. I think VEITH is also coming up. ISA will be coming around. So I mean, especially for the early career young trainees, I mean, go to these things.
Yeah.
More for bouncing ideas off each other and hearing what's coming out because it's going to start increasing rapidly what's coming out, and I think you got to stay abreast of it.
Yeah, I mean, like I said, I don't know how you take time to deal with us with 1,000 things you're doing here. But in all seriousness, man, it's freaking awesome. Keep on doing what you do. And we look forward to your 5th episode.
I can't wait. Love you. Great talking to everybody.
Yeah, thank you.
All right.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabeen Dhand,
Michael Barraza,
Brian Hartley.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson.
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Zubi Syed,
article and transcript support by Taylor Robinson,
and Delaney Aguilar.
Social media and PR by Ann Dang,
and newsletter by Lauren Fang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.